Good afternoon and welcome to our presentation today on an update on COVID-19 documentation and coding for hospital patients. I'm Dr. Ronnie Smith, an actively practicing internist in Vidalia, Georgia, and I'm also the president of Successful Health and Wellness Solutions. Today I am joined by Carrie Hudson. And Carrie, if you would introduce yourself.
Hey everyone, I'm Carrie Hudson. I have a master's degree in education. I am also a licensed professional nurse and also have a certification in risk adjustment coding. I serve as Dr. Smith's nurse and also work with Successful Health and Wellness doing consulting services.
We really appreciate you joining us today. This is certainly unprecedented, challenging times in healthcare. So I don't want to seem insensitive to what's happening in the clinical world, but I do think the documentation and coding is going to be very important to ensure that hospital system gets appropriate reimbursement for all the intensive services they provide to the COVID-19 patients. So with that being said, let's enter our slide presentation. So this is a simplified overview of major complication comorbid factors and complication comorbid factors for Medicare severity DRGs, with a focus on COVID-19. This presentation is intellectual property. Please do not copy or distribute without the written permission of the author. All inquiries can be sent to Ronnie R. Smith, MD at ronsmithmd@mac.com. Okay, so we now will present some coding scenarios based on a 65-year-old female, and I'm going to let Carrie talk you through this slide.
So with the crisis going on now in the United States, we wanted to begin by looking at some of the different scenarios that we may see in the hospital setting. The new code that became effective as of yesterday is U07.1, which is the COVID-19 ICD-10 code that should be used. And in this slide, you can see where I've used some different conditions that have mostly been associated with the COVID-19 virus. So the J1289, which is other viral pneumonia, which is due to COVID-19, that pneumonia code with the COVID-19, when you run that through the pricer or the grouper, you'll find that you get a DRG weight of 0.6821 and you get a geometric length of stay at 2.6 days. I won't go through each one of these, but if you notice, the viral pneumonia and the acute respiratory distress syndrome, which is your ARDS, those are both MCCs, and then down closer to the bottom, you see the ventilator-associated pneumonia is a CC, which is a comorbid condition. The only one of these conditions you see that are highlighted in or that are bolded in black that is going to HCC risk adjust, which is your outpatient risk adjustment model, is going to be the ARDS, the acute respiratory distress syndrome. One thing that I want to encourage the hospitalists to do as far as their documentation is to make sure that they are coding and documenting all those underlying conditions. We are seeing that the majority, I think around up to 70 or 80% of these patients that are being hospitalized have underlying conditions.
And to give you a brief overview of those conditions, and again, we're speaking to hospitalized patients for COVID-19 with respiratory symptoms. So those comorbid conditions include diabetes at around 32%, with pre-diabetes being seen in 24%, followed by heart disease at 29%. And most of this heart disease obviously is coronary artery disease, arrhythmias, status by-post heart surgery for coronary artery obstruction, lung disease at 26%, and that includes your COPD, emphysema, and asthma. And I will point out that asthma does not CMS HCC risk adjust, but the COPD and emphysema do. So approximately 25 to 30% of COVID-19 patients admitted to the hospital will develop acute respiratory distress syndrome, and approximately 1/2 of these will die. So it's extremely important to document and capture these additional complications and comorbid factors. And as we go through our slides, we'll discuss these actually in more detail.
Okay, so here I just wanted to show, just point out that ARDS, that's the only one, as Dr. Smith said, that is going to risk adjust in the outpatient. It carries a weight of a 0.282, and it maps to HCC category 84.
Yes, and when we say outpatient, we're really referring to the hospitalist claim form 1500, which captures the HCCs as opposed to the inpatient facility, which is on a sent on a form UBO4, which captures the DRG and the associated MCCs and CCs for the inpatient stay.
Okay, so for possible exposure to COVID-19, but then it's ruled out after the evaluation, that's going to be coded Z03.818. And then if the exposure is confirmed to have COVID-19, if the patient is in contact with someone that is known to have COVID-19, that code is going to be Z20.828. And you want to make sure that you do not code the U07.1 if it's only suspect at this time. So some billing codes, the lab billing codes. If the test is performed at a CDC laboratory, you're going to use U0001. And if it's tested in a non-CDC laboratory, it's going to be U0002. And here's one of this is our newest tool. This is our MCC and CC tool. And it has the most common MCCs and CCs that you would see in the MSDRG model.
So one emphasis that we would like to reach out to the physicians attending this webinar is knowing that CMS and commercial payers consider coding clinic, which is published by the American Hospital Association, to be the official source for coding guidelines. So in October of 2016, this coding clinic came out, which addresses code assignment and clinical criteria. And we quote,
"The assignment of diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient. Code assignment is not based on clinical criteria used by the providers to establish the diagnosis." Dr. Smith, just tell them what that means.
So this is saying if a physician or a non-physician practitioner makes a diagnosis based on their clinical decision-making and best judgment, that is in fact the diagnosis. That really cannot be questioned by an auditor or a reviewer. Those auditors can question that we capture the appropriate elements in the documentation to support our diagnoses, but you'll find that our diagnoses will not be challenged, if we have that supporting documentation in our clinical notes.
Per CMS Risk Adjustment Data Technical Assistance Guidelines, physicians should document all conditions that coexist at the time of the face-to-face encounter or visit and require or affect patient care, treatment, or management. Do not code conditions that were previously treated and no longer exist. However, history codes may be used as secondary codes if the historical condition has an impact on current care or influences treatment. And this is something that we see different in value-based care model as opposed to fee-for-service, as far as providers needing to document and code more than just the reason for the visit. We're trying to paint that clear picture now.
So in the inpatient perspective, this is really saying that it's really important from hospital admission, and certainly within the first 24 to 48 hours, that we not only state our differential diagnoses and what we believe the principal diagnosis will ultimately be after study. We need to also begin to document these major complications and comorbid factors, in the chart. So what I'm referring to is, the ARDS, has that been established? Is the patient diabetic? Does this patient have diabetes with manifestations and complications in its own diagnosis of diabetes? Does this patient have angina? Does this patient have COPD and emphysema? And does this patient have morbid obesity? I left that out of my initial list, but it's been discovered that a very high percent of comorbid 19 patients are obese. There's been a lot of interest in why that is, but that is indeed to be found factual.
How to document for inpatient coding. The principal diagnosis is defined as the condition after the study which occasioned the admission to the hospital according to CMS and ICD-10 official guidelines for coding and reporting. We must remember that the principal diagnosis is not necessarily what brought the patient to the emergency room, but rather what occasioned the admission. Typically, the primary diagnosis and the principal diagnosis are the same. However, that's not always necessarily true. Now, the Uniform Hospital Discharge Data Set defines a secondary diagnosis or other diagnosis as conditions that coexist at the time of the admission or develop subsequently and that affect the patient care during the current episode. Secondary diagnoses affect MSDRGs by one of the following. So with MSDRGs, we have 3 levels. We have our base level, which is a non-CC, which is non-complication or comorbidity, which does not significantly affect the severity of illness and the resources that are used. That second level is your CCs, which is a complication or comorbidity, which is the next level of severity. And then your MCCs, which is your highest level, is a major complication or major comorbidity, which reflects the highest level of specificity. So we call this they're either bifurcated or trifurcated according to the level of severity.
And it should be noted that an MCC trumps a CC and a non-CC, and a CC trumps the non-CC. So, one should focus on those MCCs because that significantly increases the weight and will affect the case mix index, after discharge.
It's also going to affect that geometric length of stay and the reimbursement.
Yes. So let's talk about the influence of CC or MCC on MSDRGs. So first is pneumonia, MSDRGs for Medicare patients. We look at DRG 195, that is simple pneumonia with a non-CC. And you see the weight there and the total hospital payment and the geometric length of stay. So as we progress up, but actually the numerical number there, the lower the number, the higher the severity within a disease group. So DRG 194 is simple pneumonia with CC. It has a higher weight. It has a higher hospital payment and a geometric length of stay of 3.2 days. And then we progress to DRG 193, which is simple pneumonia with MCC, which has a substantially higher DRG weight, a substantially higher hospital payment, and a geometric length of stay of 4.2 days. And obviously, there's going to be a breakdown or disconnect here with COVID-19. COVID-19 basically ends up grouping to a simple pneumonia, a viral pneumonia, and usually a high percent of patients with sustained mechanical ventilation, which my understanding is now is anywhere between 4 to 14 days. So that's really going to cause a lot of resource consumption use. So it's going to be very difficult to maintain what I would loosely term profit margins. So I think the care of these patients will far exceed the subsequent payment. So it's really important to to capture as many of these MCCs or CCs as possible. So the COVID-19 patient in the hospital that develops ARDS would group to DRG 193. Currently, it would not even escalate to a level of a more complex pneumonia, which would be DRG 179, 178, or 177. I feel in the future that because of the gravity and severity of COVID-19, that it will fall into the complex pneumonia grouping, which is also known as respiratory infections and inflammations by the DRG coders. So these above examples are for illustration purposes only. May vary based on multiple factors, including location.
So let's look at the difference in inpatient coding and outpatient coding. With your inpatient coding, your diagnoses that are stated as probable, possible, or suspect, or rule out can be coded, while in the outpatient world, those conditions cannot be coded. We have to have a definitive diagnosis in outpatient to be able to code those.
So in the outpatient world, without establishing a firm diagnosis, you would basically code the symptoms, and very rarely does a symptom qualify as a HCC risk-adjusted diagnosis.
The hospitalist or admitting physician must document the patient's severity of illness in the admission H&P and/or progress notes to assist HCC and MSDRG coders by doing the following three things. First of all, they need to explicitly state the principal diagnoses, the known secondary diagnoses, and recognized HCC RAFs on admission, followed by any supporting details. Example of this would be severe sepsis with specific criteria met to make the diagnosis. The second thing is explicitly stating all secondary diagnoses and HCC RAFs recognized or discovered after admission H&P, followed by any supporting details. An example of this would be toxic or metabolic encephalopathy, systolic congestive heart failure, alcohol dependency, and then you would also want to make sure that you are including a status update to these conditions, stating if it's improved, worsening, stable, controlled, better, however you would want to describe that, but you would need a status update on each one of the conditions.
Carrie, since we haven't defined it for our viewers, would you define HCC and RAFs?
Yes, your HCC is hierarchical condition category, and then RAF is risk adjustment factor, which is any diagnoses that will risk adjust.
Very good.
And then the third thing is they need to explicitly state each diagnosis was present on admission. So in other words, pneumonia, sepsis, congestive heart failure, and state that they were present when the patient was admitted.
So these need to be included in supporting in the initial differential diagnoses. You know, if you wait several days into the hospital stay after discharge, the DRG coder using the grouper and a pricing software would not be able to construct the different scenarios for highest payment. You know, these diagnoses, even though they may be multiple, such as we listed here as an example, they really need to be captured, you know, initially in order for the appropriate documentation to support the coding. So it's not always in the coding. I think the magic is in the physician's documentation, in their clinical judgment. Did these conditions or the possibility of these conditions actually exist in the physician's judgment on admission? And frequently you will see a combination of 2 or 3 of these that we've given in the example.
So don't wait to document the principal diagnosis, secondary diagnoses, and HCC RAFs until the discharge summary and the final diagnosis. So MSDRGs for CMS grouper for Medicare inpatients. This is going to be your Part A for Medicare. It's been in effect since 2007. It applies for all of our Medicare patients and some states for Medicaid. It applies for Georgia, and then some states for workers' compensation. Then you have your APR DRG, which is your all-payer refined DRGs, which is your HHS. This is your ACA exchange plans, your Obamacare plans. That's a grouper for 3 months by 3 months for all ages. It has been in effect since 2012. It is for the majority of states for Medicaid, and you have a few of the examples of those states there. And then many states for workers' compensation as well, and then also some commercial plans.
So what determines a Medicare severity diagnosis related group selection? Obviously, the number one is the principal diagnoses, followed by secondary diagnoses, followed by significant inpatient procedures, and these are mostly in the OR. And these do not include endoscopy, whether GI or bronchoscopies. Also, the use of mechanical ventilator over 96 hours or longer will impact the final weight and payment. Also, the age, gender, and discharge status of the patient. It goes to reason that if the patient is discharged alive, that attributes to more success, a better outcome. So that weight for reimbursement is higher than that of a patient that was discharged deceased. So that was a brief overview. We hope it was clear. If we need to clear up any of the confusion we may have caused you, please feel free to send us your questions. So I will ask our moderator if he will see if we have any questions in the chat box or any other questions.
Hey, Dr. Smith, looks like there was a question that came in that was asking, you mentioned a tool you showed. What does that do for me when I'm documenting on these patients?
Well, that's an excellent question. So we've tried to simplify, clarify things for, the actively practicing physician. So this tool serves as a prompter, and by using it and studying it, the physician can get a general idea of what the most common major complication comorbid factors are. That's where the initial focus needs to be, is finding that MCC. And again, in COVID-19, that would be that acute respiratory distress syndrome that really is going to cause that patient to be placed on a ventilator. And then there's a section for study on just complications, comorbid factors. That's important. And it also lists some of the HCCs, which we also have in another tool. And it's really important for global risk assessment. So in the hospital, you have two forms of risk assessment. You have those HCC RAF diagnoses that is captured on a form 1500 for professional services by the hospitalist or a physician who admits. And then you have the CCs and MCCs for the inpatient side that will affect the hospital's claim form, the UB04. So you got two separate levels of risk adjustment capture. And again, on the HCC side, that also includes hospital outpatient and the physician's office or clinic. So, those are very important for physicians to be aware of, and in value-based healthcare, they're essential to optimizing your financial and quality outcomes.
I know that the tools that you use for your physicians in the outpatient world, they have those in the patient rooms. What about this one? If I'm a hospitalist and my hospital wants to use the tools like this, do we keep them on a chart? Do we keep them at the patient or at the at the desk? How do we use that in our practice?
Well, I think the general knowledge should be shared with the case management team, the utilization management team, but also the best location to keep these is in the dictation areas at the hospital, where the physicians, they sit or lounge around and they dictate their notes. So if they have this as a quick reference on a side table or wherever, and also they should carry one home or to their office if they have an office practice, and they should spend some time overlooking these tools, because they are a tremendous return on investment for the knowledge gained. And many physicians are really not aware of how the MCCs and CCs affect the DRG payment, as well as their HCCs, in comparison, like physicians compare in the outpatient world. So they just need access to this tool at the hospital, and I think for their own personal purview and study.
Dr. Smith, would you agree that the pricers and groupers need it as well, since in inpatient, they're usually the ones that are doing most of the coding?
Yes, absolutely. And then we have two worlds colliding in the hospital coding department. We have your traditional DRG coders, which put the codes in a grouper, and then they can rearrange the principal and secondary diagnoses to optimize in the pricer. So that is perfectly legal to do, and without question is the wise thing to do. So in many hospital systems, they then have the HCC coder, to come in and help capture all of those HCCs that's going to impact the form 1500 for outpatient and inpatient professional services. Is that kind of confusion?
No, that's great. Do you offer similar, and today we were focused on the hospitalists themselves and things they needed to think about. Do you offer similar type of in-service information for, you talked about the groupers, the coders, those folks? I would imagine you can probably share some similar information for them if they need it.
Absolutely. Global risk adjustment is a team sport. We've got to involve everyone so we increase their awareness and also their recognition of those diagnoses or conditions that will affect at-risk payments. So everyone needs to be involved. Um, I should point out that 58% of the HCCs in the outpatient setting will actually become either an MCC or a CC inpatient that will, obviously impact coding and reimbursement.
Gotcha. When you think about practices like the hospitalist medicine groups in various hospitals, many of them are employed by that given hospital, but in some instances around the country, you'll see kind of like in an emergency room or anesthesia, an outside entity or an independent group will be managing that element of clinicians. Can you see, as you're looking at that, how one might be able to motivate those clinicians at the point of care? Obviously, the employed group, you can probably say, "Hey, doctors, we need you to attend this." But what would you say if there maybe the hospitalists in the group are not employed by the hospital? Do you see value for those doctors to do this as well? It would seem like there might be.
Yes, I do. Obviously, it impacts their macro MIPS. If they're just solo practitioners or a group that's not affiliated with an ACO. If they're members of an ACO, it obviously is going to impact the financial outcomes of an ACO. Also, on the inpatient side, I have known some health systems that incentivized private hospitalists to reduce the geometric length of stay. So that's why in our slides we included that. So I know of a couple hospital systems that actually give physicians a quarterly incentive based on a percent that they come in under the geometric average length of stay, because that adds to the overall cost efficiency and net operations of hospitals for inpatients.
I would imagine if I'm the company or the independent group that's managing that service, there's probably value in me from a marketing and sustainability of my contract perspective if I can show that my clinicians are documenting well and therefore your facility is getting to benefit from that back to against some of the things you guys talked about earlier as to how this impacts our reimbursement.
Yeah, and I would add to that, if different groups, hospitalist groups, are competing against each other for a contract with a hospital or health system, I think the ones that demonstrate greater value in their recognition of HCCs, becoming the CCs and MCCs, their recognition and management of their principal secondary diagnoses when on admission, become conditions associated with a higher weight and eventually, higher reimbursement to the hospital. So I think the more you have to share that with the hospital financial people to show that your hospitalist group is up to speed on risk adjustment and value-based health care. I think that is important in contract negotiations going forward.
One last question real quickly before we let you go. I know that one of the services that you've done a lot of work with hospitals on in particular over time is helping them go back and correct past documentation errors of some level. There may have been simple coding errors that was supported by documentation that just got miscoded. But is there a period of time, if I recognize that over time we weren't doing this kind of thing very well, that we can look backward and be able to then make some corrections? Or is it pretty much a forward-looking thing that we just got to get better from here?
Well, we got to get better from here. That's the main stay. But through audits, if you find glaring inaccuracies in what was documented and what was failed to be coded to the high specificity, you would basically have to resubmit those claims for re-adjudication. So that is obviously time consuming and very expensive. So I believe if it's flawed in the beginning, it'll be flawed in the end. So therefore, I promote the learning experience for physicians to increase their awareness and recognition and documentation to support the final high specificity codes that are selected and build on a claim form. So I think 99% of your effort needs to be on the prospective education rather than on retrospective review. But the retrospective audits are very important because they can establish the patterns and behaviors of the physicians that are not adequately documenting clinical information to support the final code. So the audits and the retrospective review, I think, are critical, to find those areas. For an example, if we have a diabetic with, say, just proteinuria, which is protein in the urine, and the physician documents diabetes and uses that code E11.9, which is diabetes unspecified, and then the patient has microalbuminuria. That code is R80.9. Just doing that basic unlinked documentation is going to cut the potential relative weight to a third of what it should be. So what should happen is that provider needs to understand that if he links diabetes with proteinuria, that is CKD stage 1, that would be E11.22, and that has a relative weight of 0.302, which is substantially higher than the 0.105 if those two conditions were not linked and coded.
That makes sense. I appreciate you making time. Do you have any final thoughts before we let you get back to the day? And then we'll come back again for another session. We want to make sure that if folks didn't get to attend today's live session, where they might be able to come up with questions that we can answer for them while we're here. Make sure you get into the registration room, and you can come back. Even if you joined us today, come back for another live session. We're going to be talking about this a little bit clearly. A lot of doctors out there dealing with this. So before we let you go, Dr. Smith, any final thoughts?
I think Carrie has a couple comments. You know how the ladies are.
I would just like for Dr. Smith to make a couple of comments and maybe talk about how this benefits the patients. We talk so much about how it affects healthcare in general, how it affects the providers. We talk about a lot of things financially, but here at Body Medical Associates, Dr. Smith actually will talk about risk adjustment with his patients. They seem to enjoy it. I don't know that they really understand it a lot of times, but I just like for him to make a couple of comments on the benefits for the patients instead of it,
Yeah. Well, I think first of all, the clinical team and the team documenters, it's really important to better understand the patient's burden of chronic disease. So I think the risk adjustment scores and what diagnoses risk adjust really help us to focus more, in those areas. I kiddingly tell my patients as I discuss what this process of risk adjustment, their conditions are, I tell them that this actually increases my spending budget for them in the next calendar year. And they do seem to appreciate and understand that. And a frequent comment that they offer is that I've never had a physician do that before. So, I do enjoy that engagement with the patient, to let them know that I'm trying to do the best I can to make them healthier and happier. But I also have consideration of the stewardship of resource consumption. And I certainly don't want to be perceived as a cost inefficient provider or an overutilizer of services because I failed to document their health status and chronic burden of disease. So with that being said, I want to thank everybody for joining this COVID-19 discussion today. For my peers and colleagues on the front lines of the pandemic, my thoughts and prayers for your safety and health as we face this together.
Thank the two of you for joining us and making this information available. I'm real excited to be bringing it to our peers out there.
Hey, thank you very much.
See you guys.
Bye.